بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we will continue the second part of the lecture about the pediatric brain tumors. We have classified these tumors into according to the anatomic sites as tumors occurring in the posterior fossa, the supratentorial tumors, intraventricular, suprasellar, pineal body, congenital tumors, and the tumor-like cystic structures, cystic lesions. We have finished in the first part the tumors occurring in the posterior fossa as well as those occurring in the supratentorial area. Now we will discuss the intraventricular tumors and the rest of the other topics. Intraventricular lesions are mainly in all age groups are the ependymoma and the choroid plexus papilloma and the other intraventricular lesions. In the pediatric age group, we have the subependymal giant cell astrocytoma of tuberous sclerosis and the central neurocytoma as well. Then choroid plexus papilloma represents about 3% of all pediatric intracranial tumors, and most of these tumors occur below the age of 5 years. These tumors arise from the choroid plexus, which is responsible for CSF production. So you can expect in functioning tumors that there is overproduction of the CSF, and this will lead to the development of what's known as non-obstructive hydrocephalus. But these tumors also can bleed and they can obstruct the CSF flow, so the hydrocephalic changes are augmented by an obstructive element as well. These tumors occur mainly in the lateral ventricle in the pediatric age group, and they are seen in the fourth ventricle in adults. Most of these tumors are hypervascular and they are liable to bleed, and also the choroid plexus usually develops calcification in adult age, and then also the choroid plexus papilloma and carcinoma can develop calcium. These lesions are hypervascular. They will enhance markedly after injection of contrast. You see this lobulated tumor inside the left lateral ventricle and has a component also in the right lateral ventricle. The tumor, although being a benign lesion, but it can spread by CSF and produce CSF metastatic seedling. The tumor mainly occurs in the trigone of the lateral ventricle in the pediatric age group, but in adults it is usually seen in the fourth ventricle. And you should also know that the tumor can have multiple foci, and this occurs in about 4% of the cases. Hydrocephalus is very common, seen in more than 90% of the cases because of the CSF production and also the CSF obstruction flow. You see this is sagittal T1 weighted image before contrast, and this is after contrast. You see a tumor in the trigone of the lateral ventricle, and the tumor shows a strong post-contrast enhancement. And this is also a good example of choroid plexus papilloma by CT before contrast injection and after contrast injection. You see a tumor totally confined within the ventricular lumen, and it shows strong post-contrast enhancement. This tumor is not secreting CSF, so you do not see ventricular dilatation, but this is the sagittal T1, axial T2, and coronal T1 post-contrast, showing the classic tumor in the trigone of the right lateral ventricle of intermediate signal in both T1 and T2 weighted images with homogeneous post-contrast enhancement. And this is also a choroid plexus papilloma in the lateral ventricle in the left lateral ventricle, T1, T2, and T1 post contrast. Another example of choroid plexus papilloma in a female infant 3 months old by CT post contrast and MRI T1, T2, and T1 post contrast axial and sagittal images showing a lobulated tumor mass in the trigone or in the occipital horn of the right lateral ventricle with element of ventricular dilatation due to the CSF overproduction, as I have mentioned before. And one of the tumors that are also seen inside the ventricle in the pediatric age group, which is the giant cell astrocytoma, occurring in a patient with tuberous sclerosis. And you know, the tuberous sclerosis is diagnosed by the presence of multiple subependymal tumors in the wall of the ventricle. The tubers subependymal tubers in the wall of the ventricles. The tubers will show calcium later in life. This is an infant, and if you inject contrast, they will enhance. And some of the tubers may be seen in the cerebral parenchyma, in the cortex of the brain tissue. And one of the manifestations of tuberous sclerosis is the presence of this tumor in the frontal horn of one of the lateral ventricles near the foramen of Monro. And this tumor will show homogeneous post-contrast enhancement and it will contain calcium. And this is an example for the diagnosis of this tumor, subependymal giant cell astrocytoma. You should see in the CT or MR studies manifestations of tuberous sclerosis in the form of subependymal tubers which are calcified. And this tumor is located in one of the frontal horns. It will show homogeneous post-contrast enhancement in most of the cases. And if it is large like this one, it will encroach in both foramina of Monro, resulting in obstruction of the flow of the CSF flow in the lateral ventricles, which are then will be dilated. This is also a third example. You see calcium in the wall of the ventricle, and this is one of the major stigmata of tuberous sclerosis. And you see a lesion in the frontal horn of the right lateral ventricle, which also contains calcium, and after contrast injection, it shows homogeneous post-contrast enhancement. This is an MRI of a patient with tuberous sclerosis. You know that MRI is less sensitive than CT for detection of calcium, but still you can see the tubers in the wall of the ventricle. They show some increased signal in the T1 and a decreased signal in the T2 due to the presence of calcium. And in the frontal horn of the left lateral ventricle, you see a lesion which shows bright signal in FLAIR images and intermediate signal in T2 weighted images representing a subependymal giant cell astrocytoma. Then one of the intraventricular tumors which occurs in young adults is not in the pediatric age group actually, but it is seen in adolescent patients. And this tumor occurs in the lateral ventricles. It is a low-grade tumor, WHO grade 1, and is usually seen in the body and may occur near the foramen of Monro. And it is relatively rare, represents 0.3% of all intracranial tumors, and usually it presents by signs of increased intracranial tension. The tumor is characterized by the presence of calcium and the presence of cystic changes. And then if you see a lesion within the lateral ventricle, which contains calcium and cystic areas, which are one of the prominent features of this tumor, and this tumor may obstruct the CSF flow, resulting in hydrocephalus. Then you look to the edge of the patient, and you can appreciate or diagnose the possibility of central neurocytoma. This is a female 17 years old presenting with headache, and this is the tumor in the left lateral ventricle showing some foci of calcification and also minute cystic changes and it is a good example for central neurocytoma. And this is also a good example for central neurocytoma in a female 18 years old. This is T1, T2, the flare, and T1 post contrast. And you see the cystic areas within the tumor showing low signal in the T1 and high signal in the T2. Of course, MRI is less sensitive for detection of calcium compared to the CT scan. Then we proceed to the supracellular tumors, which are some of them are common in the pediatric age group, and this is one of them, which is the craniopharyngioma. The craniopharyngioma is a supracellular tumor. It represents about 1.2 to 3% of intracranial tumors. It has a peak in the pediatric age group in the range in the age between 6 and 10 years, and also another peak in adults around the age of 50 years old. The tumor is is almost a midline tumor occurring in the supracellular area. And for the diagnosis of the craniopharyngioma, we should have three main findings. Number one is the cystic component. Number two is solid component. Number three, calcium. Then if you see the three components in a child or in an adult in the midline, you may be able to diagnose the possibility of craniopharyngioma. And also you should remember that two of these three criteria may be present, and you can also diagnose craniopharyngioma, but one of these two should be the cystic component. And if you have a cystic component and a solid component, you can diagnose craniopharyngioma. If you have a cystic component and calcium, you can diagnose craniopharyngioma. Then you know MRI is less sensitive for detection of calcium. This is a cystic component in the supracellular area in a child, and it has a marginal calcification. You don't see a solid component. Then you have two of three diagnostic stigmata, and you are able to diagnose the craniopharyngioma. You know that the craniopharyngioma, the cystic component, may contain a fluid like the motor car oil. And in this situation, the signal intensity of the cyst component will be high in the T1 and also in the T2 weighted image. Then here you can see this high signal cystic lesion in the supracellular area in a female child, and it also shows some signal increase in the T2 weighted images, and then you can diagnose at that time the possibility of craniopharyngioma because of the signal intensity of the fluid inside the cyst. Also, the hypothalamic glioma and the gliomas occurring along the visual pathways are also seen in the pediatric age group, and they represent about 25% of the pediatric supracellular neoplasms, and about 75% of these tumors occur in the first decade of life. And this diagram shows the visual pathways starting from the optic nerve to the chiasm to the tract, then ending by the visual pathways, the visual radiation or the visual cortex. Then, if you see a lesion which is in the supracellular area showing almost homogeneous contrast enhancement in a child with no evidence of calcification, then you may think of hypothalamic glioma. And this is an example. In MRI, the lesion will show isointense signal in the T1, high signal in the T2 weighted images. The lesion do not contain hemorrhage, and it will show enhancement, either homogeneous or heterogeneous. And this is a good example of hypothalamic glioma in a child 10 years old. The lesion is of intermediate signal. It is solid in the supracellular area in the T1, and bright signal in the T2 with almost homogeneous post-contrast enhancement after injection of gadolinium. This is the difference between hypothalamic glioma and the craniopharyngioma in children. The hypothalamic glioma is a solid lesion, while the cystic component of craniopharyngioma is essential for the diagnosis. Craniopharyngioma contains calcium, one of the stigmata, but the hypothalamic glioma do not contain calcium. Hypothalamic glioma is of low signal or intermediate signal in the T1, but sometimes the cyst of craniopharyngioma will show high signal in the T1 due to the lipid content of the cystic fluid. This tumor, hypothalamic glioma, will show homogeneous or heterogeneous post-contrast enhancement, but this tumor, the solid component, only enhances and may be the margin of the cyst. This tumor may infiltrate the visual pathways, including the optic tract and the brainstem and the thalami, but this tumor is not. This tumor, hypothalamic glioma, has an intimate relation to the neurofibromatosis type 1, and craniopharyngioma is not. Then the lesions seen in cases of neurofibromatosis type 1 affecting the visual pathways may be in the form of hamartomas or gliomas. In order to differentiate between both, it is only the enhancement. In cases of glioma, the tumor will enhance. In cases of hamartomas, the lesions will not enhance. No enhancement, no mass effect, and no surrounding edema. You can diagnose that the lesions you are seeing in MRI are of hamartomatous nature, not gliomatous nature. And this is an example of bilateral optic nerve glioma. You remember the tortuosity of the optic nerves and the soft tissue masses, and they proceed to the chiasm. And in the same case, in the CMS in the suprasellar area showing homogeneous, almost homogeneous post-contrast enhancement, completely separable from the pituitary gland. And this is neurofibromatosis type 1 with bilateral optic nerve glioma and hypothalamic glioma as well. And this is the case of neurofibromatosis type 1. The lesions infiltrate the visual pathways and they show low signal in the T1 with post-contrast enhancement, denoting that they are of gliomatous nature. One of the lesions which is seen in children is the tuber cinereum hamartoma. What is the tuber cinereum? It is part of the hypothalamus where you can see this tuber cinereum on imaging. Look to the sagittal MRI, and this is the pituitary gland, anterior pituitary and posterior pituitary. The posterior pituitary is usually bright due to the presence of more triglycerides inside. Then the pituitary gland is connected to the hypothalamus by the infundibular stalk. If you follow the stalk, and you will reach this small nodule which is known as the mammillary body. Then between the mammillary body and the end of the pituitary stalk, there is a line like this, and this is the area of tuber cinereum. And tuber cinereum hamartoma is a benign lesion arising from this part of the hypothalamus, and it is more common in boys than in girls, usually presents by precocious puberty and sometimes with seizures, and maybe both precocious puberty and seizures as well. The most important diagnostic feature of this tumor is no enhancement. And here you see this is the lesion arising in the typical area of the tuber cinereum. After contrast injection, the tumor does not enhance and the pituitary gland has enhanced it, as you can see here. And this is also another lesion in the suprasellar area with no enhancement after contrast injection. Typical location and typical appearance on MR imaging. The tumor size is in the range of 2 centimeter, but sometimes you can see larger tumors than this one. Then the next category are the pineal body tumors. We will discuss the germinoma, teratoma, pineoblastoma, and the pineocytoma. Of course, in order to diagnose the pineal body tumor, you should see a tumor in the region of the pineal body where the pineal body is located within the quadrigeminal cistern. And as I have mentioned in the lecture of anatomy. Then you see a mass here, which is located in the midline along the posterior aspect of the third ventricle. And this tumor is commonly calcified because the pineal body normally calcifies in adult patients. And this tumor is usually associated with obstructive hydrocephalus due to its intimate relation to the posterior aspect of the third ventricle as well as the aqueduct of Sylvius. Then, whenever you see a lesion in the midline within the quadrigeminal cistern along the posterior aspect of the third ventricle, and it may contain calcium, then you say that this is a pineal body tumor. You know that we have 5 types of pineal body tumors: the pineoblastoma, pineocytoma, pineal germinoma, pineal teratoma, and pineal metastasis. Actually, you cannot discriminate between these tumors by imaging unless you have some positive criteria. And this is a tumor which is located within the quadrigeminal cistern along the posterior aspect of the third ventricle. The tumor is enhancing, containing a focus of calcium. And after contrast injection, you see a strong homogeneous enhancement. By MRI, the tumor showed intermediate signal in the T2 weighted images, and it shows enhancement in the sagittal T1 weighted image. Then you say that this is pineal tumor, and you cannot predict if it is germinoma or not unless after surgery. But you can diagnose pineal teratoma if you see fat inside the tumor, and you know that fat will appear of bright signal in the T1 weighted images, and this is a tumor of mixed signal with some brightness in the T1 denoting the presence of fat. And at that time you can diagnose that this pineal body tumor is in particular represents a pineal teratoma. And this is an example. The pre-contrast T1 weighted image shows the focus of high signal representing fat, and after contrast enhancement, the tumor is enhancing and the fat is seen. One may say that this bright focus may represent hemorrhage, and you are right. Then we should have the fat suppression technique to be sure that this focus of high signal will represent fat and not blood. For the diagnosis of pineal germinoma, from imaging, you should see another tumor in the suprasellar area, what we call the ectopic pinealoma. And if you see a mass in the pineal body region and another mass in the suprasellar area in the same patient, then you can say that this is germinoma and this is also germinoma. And this is an example. You see a mass in the pineal body, small mass, and another one in the suprasellar area. Then the sagittal image is a mass in the pineal body and another one in the suprasellar area. Then you may be able to diagnose pineal germinoma. You can diagnose pineal metastasis if you know that the patient had a primary malignancy, and this is seen in adults, of course, when the patient had a primary malignancy like this one, having lung cancer, then you diagnose this as a pineal metastasis. Then we came to the congenital tumors, and we have discussed these tumors in the lecture of cortical formation. And we mentioned that we have 2 types of tumors due to abnormal proliferation of the cells at the germinal matrix in the ventricular wall. And these tumors are an intermediate station between cortical dysplasia and true neoplasm. And I have mentioned that in order to reach the diagnosis of these 2 tumors, which are the dysemperioblastic epithelial tumor and the ganglioneuroma, then you should see calvarial remodeling adjacent to the tumor. And that's because the tumor is congenital and is slowly growing with no significant manifestations, and it will affect the inner table and maybe also the outer table of the calvarium. And here you see a lesion which is of hypodense texture in the CT images, and in MRI it is of low signal in the T1 and high signal in the T2. If you inject the contrast, it will not enhance. And so they usually say in the literature that this tumor may be mistaken for an infarction. But if you look carefully, that the lesion is indenting the calvarial bones, as you can see here. Then the second one is ganglioglioma, and this lesion is also seen in children and may present in adults because of little manifestations. Then the tumor is seen usually in the temporal lobe, and frequently it contains calcium. But what's very important is the presence of calvarial remodeling. As you can see here, there is a tumor mass indenting the calvarium, and the tumor is containing calcium. This is MRI T1 and T2 weighted images of a mass in the temporal lobe, and this mass is associated with calvarial indentation. And after contrast enhancement, this tumor will enhance, as you can see here. Frequently, because of the presence of calcium, these tumors are misdiagnosed as oligodendroglioma. But this important sign, which is calvarial remodeling, will enable you to reach the proper diagnosis. Some patients may be presenting immediately after birth by different types of brain tumors, and this is one of the examples, the congenital teratoma, a very big, huge mass containing fat and other tissues involving both cerebral hemispheres, representing congenital teratoma. And also, glioblastoma multiforme can occur immediately, and or you can diagnose the patient after birth, meaning that it occurred intrauterine, and you see a mass in the right cerebral hemisphere with heterogeneous enhancement typical of glioblastoma multiforme. Finally, we reach the cystic lesions, and we would like to mention some words about the arachnoid cyst and the epidermoid cyst. You remember from the lecture of cystic lesions in the brain that arachnoid cyst represents about 1% of intracranial masses. It has a CSF density in CT and signal intensity in MRI. This lesion will not enhance, it does not contain calcium, and the most typical site for the arachnoid cyst is in the temporal region against the greater wing of the sphenoid bone. But it can also occur at the cerebellopontine angle or posterior to the cerebellum, as I have mentioned before, or in the suprasellar area, or even inside the ventricle. But this is the typical site for arachnoid cyst. In the T1 weighted images, it shows CSF signal, and in the T2 weighted image, it also shows CSF signal. And this is arachnoid cyst, T1 weighted image. And in the diffusion weighted images, the arachnoid cyst will show free diffusion in contrast to the epidermoid cyst, which will show restricted diffusion. And this is in arachnoid cyst in the sylvian fissure, showing free diffusion in the diffusion weighted images. And this is arachnoid cyst in a typical location within the sylvian fissure, low signal in the T1 and the high signal in the T2 weighted images. An epidermoid cyst is also a hypodense lesion in the CT images, low signal in the T1, high signal in the T2, almost similar to the arachnoid cyst. But the epidermoid cyst, its most common site is the cerebellopontine angle. It has a lobulated outline compared to the arachnoid cyst, which has a smooth outline, and the epidermoid cyst may show calcium, while the arachnoid cyst do not show calcium. An MRI, the epidermoid cyst will show low signal in the T1 and high signal in the T2, but in the FLAIR images, it will show heterogeneous intermediate signal. while arachnoid cyst in the flare will show low signal similar to that of the CSF. And this is the comparison between arachnoid and the epidermoid cyst. Arachnoid cyst and the epidermoid cyst in the T1 weighted image will show similar features, but the epidermoid cyst will show some lobulated margin. In the FLAIR images, the arachnoid cyst will show free diffusion, while the epidermoid cyst will show heterogeneous signal due to in the FLAIR images, arachnoid cyst will show low signal similar to that of the CSF, while the epidermoid cyst will show heterogeneous signal which is not similar to the CSF. In the diffusion weighted images, the arachnoid cyst will show free diffusion similar to the CSF, while the epidermoid cyst will show restricted diffusion, which will be bright when the CSF is black. هذا وبالله التوفيق والحمد لله رب العالمين. Thank you very much.